So I'm Dr. SJK. I'm the ENT faculty. For the next days, it's going to be fun and frolic where you're all going to get immersed in the concepts of ENT. ENT is a peculiar subject where you will see only microanatomical structures. In surgery, you see a hernia, you palpate a hernia, you get to know what is the anatomy and what is the surgery you're going to do. But ENT, you could never see any structure. It is all microanatomy. You just have to imagine yourself, this will be like that. So, with that understanding, I'm going to introduce you to the world of three-dimensional anatomy and whatnot. I'm going to tell you a lot of conceptual stories, evolution stories, my clinical experience, and it's going to be fun. Okay, so that's the intro. And another thing, I could see a panic among all the students after the last NEET exam. You don't have to panic. Okay, see, I designed this workbook some 3 years back. Okay, so while designing the workbooks, I was given instructions that, see, Dr. SJK, so you should have all the previous year questions covered. Okay, so that's the instruction given to me. But being an ENT faculty, I have read a lot of ENT textbooks and I know what is important in ENT and what you should definitely know to grab the knowledge from ENT. So I have designed this workbook in such a way it should go in a flow. It should not be haphazard. It should not be bits and pieces kind of workbook. But what happened now? I had at least some 20-25 pages which were not among previous year questions. But every year I'm getting at least 2 questions from the chapters or the concepts which I added which were not previous year questions. Can you get my point? So for example, I have added subglottic stenosis, classification name, and what should be done in subglottic stenosis. That question was asked in previous NEET exam. And 1 year before, I added this classification of pars tensa and pars flaccida retraction. Okay, so that was asked in last year's INI-CET. So the thing is, we have brought the essence of entire ENT in this particular workbook. So you can believe this workbook, trust this workbook, and you could strongly rely upon this workbook. Okay. So with that note, I could see only few good mornings. So see, I will be in no hurry to finish my class. So I will make sure that most of you are understanding the concepts. Then only I'll proceed further. So I saw only 5 good mornings. Okay, so I don't like this. So everyone, keep your chat box open. You interact with me as much as possible then and there. Okay, yeah, that's the spirit. I could see a lot of good mornings from me. So that indeed lit up the class. So we'll straight away start with the class. Okay, so the class works like this: first ear, then nose, then pharynx, then final larynx. Okay, so good morning, my dear students. Okay, I feel very happy and privileged to take the next 3 days class with you. So it's going to be an interesting and interactive session. The first, I'm going to play a video. I'm going to tell you a story. So with that story, we're going to start this narrative and the discussion. Can you get my point? Yes. So just pay attention to the story. So we'll start with this particular video to make things interesting. Okay, just listen to this video and audio. It will be interesting for you to have a grab on the concept which I'm going to explain. So that's the end of the video. So what this video implies is not a factual story, it's a real story. Some billions of years ago, the world was full of water. At those times, fishes were the only known living things. No land animals, nothing. So the world completely filled with water, a little bit of land, the water is full of fishes. So at that time, you just imagine some two fishes were living by name Nemo and Dory. Both were having conversation with each other. So why don't we get into the land which is not occupied by any animals? So the thought of those two fishes slowly became motive for evolution. So fishes slowly became amphibians, amphibians slowly became land mammals, mammals became monkeys, monkeys finally became human beings. So this is how fishes evolved into human beings. We were told that humans evolved from monkeys. Yes, they were immediate predecessors, but the ancestors for all the living things present in this world are the fishes. Okay, so it's not a cooked up story, it's a real fact or evolutionary aspect. Why I am telling this here, because we are going to start our class with the embryology of ear. For understanding embryology of the ear, you should understand embryology of pharyngeal arches. Okay, so let's start. So we are going to start with pharyngeal arches. Okay, can anyone say what is the other name for pharyngeal arches? Can anyone say what is the other name for pharyngeal arches? It's a brachial arch or a bronchial arch. Okay, so why is the name brachial arch? Did anyone think like that? So brachy is something that is associated with, or bronchi are something that are associated with breathing. So does the pharyngeal arches in human beings form any structures related to breathing? No. In fishes, the pharyngeal arches, or otherwise called bronchial arches, were supposed to form gills, which are all the apparatus for breathing. To commemorate the evolutionary point, they are still written in the name bronchial arch, whereas no other factual reason exists for the name bronchial arch. Okay, so pharyngeal arch was otherwise called as bronchial arch because previously it was forming structures of the respiratory apparatus. That is the reason we are still having the name bronchial arch. Okay, now the pharyngeal arches in fishes had some 1 to 6. Okay, so the 1 and 2 in fishes will form different structures, whereas 3 onwards was forming gills. Okay, so the 1 and 2 is same in humans. Okay, whereas the 6, the gills are not present in human beings, so modified structures are seen. I'll tell you how. The 1 is called mandibular arch. The fishes are having mandible, we are having mandible. Easy. The 2 is called hyoid arch. The fishes are having structures that support the head and thorax. They don't have neck, but that support the head and thorax. Hyoid arch. This hyoid arch also present in human beings. But 3 to 6 we don't have gills, whereas we are having a well formed neck, which is pharynx larynx, which was not present in the fishes. The gills in the fishes were modified into structures called pharynx and larynx in human beings, which was supposed to be a critical structure that connects head with the thorax. Understood? So now we are going to modify the 3 to 6 pharyngeal arch to our favor. The third arch, fourth arch, and then sixth arch. The fifth arch disappear. Okay, the third and fourth arch, this one will form pharynx. The fourth and sixth arch will form larynx. Still not convinced, sir? Why are you telling this particular story at the start of the class? See here, the fishes don't have ears, but the human beings are having ears. The pharyngeal arches of the first and second arch are modified to form the hearing apparatus. Okay, with that note, I'll tell you a concept. The inner ear was present in fishes for balance mechanism. While swimming through the water, the fishes can't able to position themselves. Further, they were having inner ear meant for balance and positioning, whereas fishes don't have ears for hearing. So the pharyngeal arches are slowly modified into external and middle ear. Sir, inner ear. Inner ear is not formed from pharyngeal arches. It is formed from neural ectoderm, which was also the case in fishes. Fishes also this inner ear was formed from neural ectoderm, whereas human beings, a fresh structure was formed. External middle ear was formed from pharyngeal arch. What are the structures we have under external middle ear? We have pinna, we have external auditory canal, we have tympanic membrane, and a middle ear cleft. Let's dive deep into this, how these structures are formed. See here, the first and second pharyngeal arch will have three different layers. One is an ectoderm, the second one is a mesoderm or mesenchyme, the third one is an endoderm. Just look into this picture, beautiful picture. Here, the three layers of the first and second pharyngeal arch are all meeting at this particular junction. Can you see? Are all meeting in this junction. What is happening? The mesenchyme of first arch will form malleus incus. The mesenchyme of second arch will form stapes. So this forms the middle structure. Okay. The external structure is formed by ectoderm. The internal structure is formed by endoderm. What is that internal structure? The internal structure of endoderm, or otherwise we call it as endodermal outpouching, will slowly form into tubotympanic recess. This tubotympanic recess will develop into middle ear cleft, which involves middle ear cavity and then eustachian tube. I'll repeat it. See, the middle structure mainly formed by malleus incus stapes, which is forming from mesenchyme. The external structure, external canal, forms from first ectodermal cleft. The internal structure, middle ear cleft, forms from endodermal outpouching. All these layers will unite at a particular point called tympanic membrane, which is an amalgamation of all three particular layers. Understood? With this understanding, we can slowly fill up this box. So come, so we can fill this pinna at last. Before that, we'll start with external auditory canal. So external auditory canal forms from, can you please answer? First ectodermal cleft. Okay. This malleus incus forms from first arch, mesenchyme. The stapes forms from second arch, mesenchyme. Now the tympanic membrane forms from, can someone please answer? Tympanic membrane forms from, the tympanic membrane forms from, please answer. Yes, Dr. Alex, it is all three layers. It is all three layers. Yes. The middle ear cleft and eustachian tube forms from first endodermal. Rather than calling plain endoderm, we can call it as endodermal outpouch. Endodermal outpouch. So we have completed a bit. Now we can go to the rest of the embryology. So external ear, external canal, middle ear cleft, middle ear cavity, eustachian tube, everything done and dusted. Now the muscles associated with malleus is called as tensor tympani muscle. The muscle with stapes is called stapedius muscle. So tensor tympani has first arch mesenchyme. Stapedius has second arch mesenchyme. Understood? Yes. Now we can move to pinna. So pinna has distinctive entity. Okay. So pinna develops from 6 island-like structures called as hillocks of His. Called as hillocks of His. So pinna forms from 6 hillocks of His, which actually forms from first and second arch mesenchyme. First and second arch mesenchyme. So pinna has a distinctive embryology, so it forms from mesenchyme only. The first and second arch combined forms. Now, yes, sir. So going by the embryology and evolution, the pharyngeal arches form the external middle ear, but this inner ear, which was previously forming the balance apparatus in fishes, is modified to form both the balance and hearing apparatus in human beings. So entire inner ear forms from neural ectoderm. Okay, neural, that is the structure which forms the structures of the brain will form the structures of the inner ear. Okay. Okay, sir. What is so fancy in this? Why are you stressing too much upon this? I'll tell you what. See here, this inner ear is divided into two different structures called bony labyrinth, membranous labyrinth. Okay. This bony labyrinth is an outside shell-like structure. This membranous labyrinth is an inner creamy or viscous-like structure. So bony labyrinth forms from a structure called as otic capsule, which derives from the neural ectoderm. Membranous labyrinth from the otic vesicle. Understood? Yes. Now, yes, sir. So the bony labyrinth forms from otic capsule, sir. Yes, sir. Understood, sir. The membranous labyrinth forms from otic vesicle, sir. Yes, sir. Understood, sir. Now, I am going to add upon a point. Yes, I have told you, malleus incus forms from first arch mesenchyme. Stapes completely doesn't form from second arch mesenchyme. Only stapes suprastructure will forms from second arch mesenchyme, whereas stapes has two different parts: stapes suprastructure, stapes foot plate. The stapes foot plate has embryology distinctive to the inner ear. Though the stapes foot plate is a middle ear structure, it doesn't have embryology similar to the middle ear structures. It has embryology similar to the inner ear structure of bony labyrinth. With this note, this is an important embryological point for an important disease called as otosclerosis. Which is the commonest site for otosclerosis? Stapes foot plate. Why? Because it has a distinctive embryology. Now can you understand why I am stressing too much upon this particular embryology? It's very important for your understanding of important clinical concepts. Understood? With that note, we'll proceed further. So we have seen which are the structure forms, which are all the structures in the ear. Now we can enter into proper embryological pattern of this otic capsule and otic vesicle. So first we'll start with otic vesicle. See here, I will have a linear cells that are arranged during embryology of 4th week. Okay, so that linear structure will slowly form a pit inside it. Okay, that linear arrangement of cells called as otic placode. Otic placode. This otic placode will slowly develop otic pit. This otic pit will slowly rearrange themselves till the 5th week of gestation to form two distinctive structures. The outside structure name is otic capsule. This one is otic vesicle. Otic capsule and then otic vesicle. Okay, sir. This otic vesicle further distinguishes themselves into sorry pars superior, pars inferior, pars superior and then pars inferior. Now the otic vesicle slowly distinguishes themselves into pars superior, pars inferior. The pars superior distinguishes themselves into semicircular canal and atricle. The pars inferior, saccule and cochlear duct. Okay, these are all slowly happening and it will complete by the fifth week of gestation. After that, the bony labyrinth will be staying like as it was before. The membranous labyrinth of cochlea will slowly develop, and it will form coiling of the cochlea. Cochlea will be having 2 3/4 turns. Cochlea will be having 2 3/4 turns. Okay. With this cochlear turns will be completely found by 8th week. Cochlear turns are completely found by 8th weeks. In that cochlea, we will be having 3 distinctive structures called scala vestibuli, scala media, scala tympani. These 3 distinctive structures will be forming by interscala septa. That interscala septa will be forming by 22 to 23 weeks of gestation. Understood? Yes. So that's about otic vesicle. So otic vesicle slowly develops into pars superior, pars inferior. Then pars superior has distinctive development. Pars inferior has a different development. Then cochlear turns, then interscala septa by 22 to 23 weeks of gestation. Okay. So this 22 weeks, 8th week, these were all not asked previously. But if you want to learn about embryology, these are the basic things that you know, that you should definitely know. So what I'm hopeful that if you read in this workbook, whatever questions they may ask in your upcoming exams, you will definitely answer that. Okay. So previously I was taking this online class. So the one rank holder, Dr. Anashwara Jacob, was from our online batch. She was studying our workbooks only. So INI-CET or NEET, whatever exams that you come across, you have to focus only upon this particular workbook. You should revise it as much as possible, and then you should have a thorough visual memory. So if you are having a thorough visual memory, no one will able to stop you from scoring high marks in your exams. Okay. So we'll start with the first question for the day. Which of the following structure does the saccule develop from? Please answer. I want answers from all your people. Yes, Dr. Preeti. Yes, Dr. Kritika. Yes, Dr. Divya. Dr. Alex. Dr. Srimuki. Dr. Sriram. Yes, Dr. Subiksha. Dr. Rajnandini. Dr. Preeta. Dr. Sangita. Dr. Raghavendra. Dr. Kala. Yes. Yes, Dr. Darshini. Yes, Dr. Elizabeth. Yes, Dr. Mobin. You are all answering in a great way. So happy to see you all people. With that note, the first correct answer from all you people. So the first step is good now. We are going to have a perfect journey. Okay. So pars inferior is the correct answer. Okay. With that note, we'll enter into the next topic. Why are you stressing too much upon the progression of this otic vesicle embryology? Which structure forms first? So yes, someone has asked what about this third option, fourth option. Okay, what is happening now? This This pars superior, okay, this pars superior will further develop into sacculus. Okay, so we'll be having sacculus anterior, we'll be having sacculus posterior. So structures like that. Okay, so the sacculus anterior will be forming anterior semicircular canal. Sacculus posterior by posterior semicircular canal. Okay, these are the structures that will be derived from sacculus anterior and sacculus posterior. Okay, okay, that will be little bit more elaborate too. That, thanks for asking. Okay, inner ear anomalies. See here. So we are having inner ear which is formed in a particular pattern. If that pattern is disturbed, okay. For example, so if otic pit itself not formed, we are having a different pathology. If otic capsule is formed, otic vesicle is not formed, we are having a different pathology. If pars superior is formed, pars inferior is not formed, we are having a different pathology. So with that note, we are having both otic capsule, otic vesicle not formed, which means otic pit or otic pit itself not formed, which means it is a hell of a life for the baby. The baby's life will be hell. No inner ear. If the baby is not having inner ear, she will be having no hearing, no balance mechanism, hell of a life. If the baby is having hell of a life, we are going to name it as hell. Mike, hell deformity. Hell of a life. She's having a good life so that she could dine in our table happily with us. She is not a very bad or very deformed child. Normal child with a small bit of anomaly. She could dine with us. So it is called mondini. Mondini. Mondini is dysplasia. It's not a deformity. So that is the difference. Two extremes of the diseases. Completely not forming. Michael. Formed but only 1.5 turns of cochlea present. Rather than 2, 3, 4 turns of cochlea, we are having only 1.5 turns of cochlea, which is Mondini's dysplasia. Okay, sir, we can fill the intermediate spectrum of diseases. Otic capsule alone formed, otic vesicle not formed. We call it as Bing Siebenmann anomaly. Bing Siebenmann anomaly. Okay. Then pars superior formed, pars inferior not formed. It is called Sheebi's dysplasia. Sheebi's dysplasia. Cochlear turn, not 1.5 tones, no tones. Alexander dysplasia. Alexander dysplasia. Understood? So that's why I have stressed too much upon the pattern of this development. So now you are very much sure about the pattern and you are sure about the names of the anomalies. Okay, fine. Now we'll get into more similar and commonly asked anomalies. So we are having external ear pinna anomalies without any conductive hearing loss. So these are anomalies, but they will not cause any hearing disturbance. They will cause different symptoms. The first is pre-auricular sinus. The second one is coloral fistula. So what about this pre-auricular sinus? So pre-auricular sinus, see here, This is the first arch derivative. The first 5 hillocks of his develops from first arch mesenchyme, whereas the sixth hillocks of his develops from second arch. So these two should fuse with each other at a particular point. Okay. So this is 1 to 5. This is sixth arch. So the sixth arch will exclusively form the tragus. This is the tragus. Okay. So the fusion point between these two different embryological entities will form a fusion point that should disappear at birth. If it doesn't disappear at birth, it is called pre-auricular sinus. Okay. So persistent fusion point between first and second arch mesenchyme. Okay, can you understand? The persistent fusion point between first and second arch mesenchyme is called as pre-auricular sinus. So as the name goes, it is a sinus. It has one end which is open, another end which is closed. One end is open, another end is closed. The open end is the external opening point. Okay, sir. What is the commonest site? The most commonest site is root of helix. So it has been portrayed here. It's a root of helix. But that doesn't mean that that is the only point where you would see a preauricular sinus. You may see a preauricular sinus over here. You may see a preauricular sinus over here, even over here. Okay, so we are having preauricular sinus opening anywhere around pinna. But the most common site is root of helix. Most common site is root of helix. So you would have seen this preauricular sinus for a lot of people. If it is asymptomatic, conservative management is enough. If it is symptomatic, surgical excision along with the tract. You should find the entire tract using methylene blue dye injection. Then you remove the entire tract. The best approach is supraauricular approach. Okay, fine. So coloral fistula. So coloral fistula is nothing but the first ectodermal cleft anomaly. So if there is first ectodermal cleft anomaly, which means that it is a first mandibular arch. If it is a mandibular arch, the one point of the fistula will be near the angle of mandible. See here, angle of mandible, one opening is there. The next opening is at the level of floor of external auditory canal. Okay. So actually the coloral fistula is nothing but the explosion of one type of branchial cyst. This point you would have not heard of. So branchial cyst, we are having a lot of types. Any swelling or congenital anomaly associated with pharyngeal arch we call by the name branchial cyst. Okay, the most common type of branchial cyst is type 2. Okay, among type 2 we are having a lot of subtypes. So subtype number 1 of branchial cyst number 2 is coloral fistula. That is not very important, I am just telling you. So branchial cyst, any cyst of the branchial arch is called as branchial cyst. So type 2 is there, type 4 is there, type 6 is there, many types are there. The type 2 is most common. Out of type 2, the coloral fistula is type 1, which is subtype number 1 is coloral fistula. Okay, so coloral fistula is actually a explosion of brachial cyst. That point is enough. Okay, so they didn't ask this question before, but if they ask, you should have this understanding. Okay, a treatment is surgical excision. Okay, so we'll answer the next question. A newborn had hypoplasia of the mandible and zygomatic bones, malformed external ears, slanted palpebration. Abnormality in development of which of the following pharyngeal arches will be most likely given to the condition? Thanks for answering, everyone. I want still more everyone to answer pharyngeal arch number 1. Why? Because it is hyperplasia of maxilla. Because the mandibular arch, which is the first pharyngeal arch, will form the external ears also. So that will form a lot of symptoms. Okay, fine. So one has asked, what is an explosion of the branchial cyst? Okay, I'll tell you. The branchial cyst present as a neck swelling. Okay, which means that there is some disappearance which is supposed to happen at a branchial cyst, branchial apparatus hasn't happened. So there is persistent of the branchial apparatus which is supposed to be disappeared. So if this is the branchial cyst, this is the superior end of the branchial cyst which was supposed to be intact. In some cases, if it is spreading till the floor of external aortic canal, it could explode and it becomes a fistula. Okay, it becomes a fistula. Fine. So this preauricular sinus and this coloral fistula both will have foul smelling discharge as the symptom. Foul smelling discharge. Foul smelling discharge as the symptom. Okay, fine. Understood this explosion of the branchial cyst concept? Okay, so which was supposed to be a cyst, sometimes it could break down at the other end of the cyst. So two openings will become here one opening, here one opening. It becomes a fistula. It's actually a explosion of the brachial cyst. Okay, fine. Understood? Understood, Dr. Divya. Shall I proceed? So we'll get into the next anomalies associated with embryology of ear. So we solved about external ear embryological anomalies. Now we'll solve about inner ear embryological anomalies. Now there are a few anomalies that is because of pharyngeal arches which have malformed external ear, malformed middle ear, but inner ear is normal. Okay, why? Because these are pharyngeal arch anomalies. So Treacher-Collins syndrome, where we'll be having microtia, micrognathia, maxillary hypoplasia and coloboma of lower eyelids. Golden hair syndrome, otherwise called as oculoauricular vertebral syndrome, will be having preauricular tags like this. Okay, preauricular tags like this. Hemifacial, one half of the face is completely malformed. It is hemifacial microsomia or mid-face defect. Now my question is, these two are pharyngeal arch syndromes which are having congenital hearing loss. Okay, now my question is, what type of hearing loss these people will have? They will have conductive hearing loss or sensorineural hearing loss. Someone please answer. So these are pharyngeal arch. Yes, everyone is answering correctly. Yes. Which hearing loss? Conductive or sensorineural? Yes, it was a great answer. This is the answer. You all should be very clear. You would have seen some 50-60 syndromes. Okay, uh, what to say, Perry Robbins syndrome, Wardenberg syndrome, this Pendred syndrome. Every syndrome will be having hearing loss. All those hearing loss will be sensory neural hearing loss. But we are having only few syndromes which is having conductive hearing loss, that are because of pharyngeal arch anomalies. These both will have conductive hearing loss as common between these two. Conductive hearing loss. Understood? Conductive hearing loss. Now we'll enter into the anatomy of ear. So for this you should have some orientation about ear. So for that we are going to see the three-dimensional anatomy. So ear is divided into external ear, middle ear, inner ear. The external ear is having pinna, external auditory canal, that will lead its way into tympanic membrane. So the tympanic membrane then will lead into the middle ear. This middle ear will be having middle ear ossicles associated with few muscles such as tensor tympani and stapedial tendon. Then the foot plate of stapes finally leads into the oval window, which is the gateway for the inner ear. Okay, so first we'll start with external ear. See here, this is a three-dimensional depiction. So ear, we are going slowly into the ear. This is pinna. We are crossing the pinna, entering into the external auditory canal, which is lined by skin. When we slowly bypass the external auditory canal, we will see the tympanic membrane, which is not a straight tube, it is a curved tube. That's why we are not having the right away, we are not having the view of the tympanic membrane. This is the tympanic membrane. Once we cross the pinna, we'll cross the external auditory, we'll see the tympanic membrane. So once we cross the tympanic membrane, we'll see the middle ear structures. I'm going to remove the tympanic membrane. So once I remove the tympanic membrane, we are slowly seeing the ossicles. The ossicle that first comes into the vision is malleus. This is called handle of malleus. Then we are slowly getting into the middle ear. See, this is handle of malleus. Then this is head of malleus. Then this is incus. Then this is stapes. This is suprastructure. So this is an annular ligament which is surrounding the foot plate of stapes. So this is the middle ear ossicles which are getting arranged. Okay, this middle ear will be having, this ossicles will be having two muscles. One muscle is tensor tympani muscle coming from the anterior wall attaching to the malleus. Can you see the attachment of tensor tympani? This is the attachment of tensor tympani tendon, okay, to the neck of the malleus. Another tendon, this is stapedial tendon attaching to the neck of stapes. So we saw about the ossicles and also we saw about the tendons getting connected to the ossicles. So this is the foot plate of stapes. It is leading into the oval window. Once we cross the oval window, we'll enter into the inner ear. Inner ear, we are seeing this bony labyrinth. Can you see the semicircular canal? We are seeing the semicircular canal like this. Can you see? Yes. So with this note, we'll write it down the important anatomical points of ear. Okay, the first we'll start with pinna. So pinna is having a outside boundary of helix, inside boundary of antihelix. These two are very important. A bowl like structure is Symba concha. It is very important. Then we are having a tragus. Okay, so this is an area called as incisura terminalis. This incisura terminalis is devoid of cartilage. So it can be a ideal site to put incision during ear surgeries. Okay, devoid of cartilage. This point one. This auricular lobule will be a source for of fat. Okay, so this fat can be used for doing ear surgeries. This fat can be used as a graft in ear surgeries. Okay, so that note we could enter into the anomalies of pinna. Okay, so absence of helix is called as bad ear. Fusion of helix and anti-helix is called as Mozart ear. Prominence of anti-helix is called as Wildermuth ear. So these are pathological anomalies of pinna. We are having a tubercle called Darwin's tubercle. This Darwin's tubercle is nothing but, can you see over here, a small prominence over here in the helix. So a prominence, anatomical variation. It's nothing but an anatomical variation. No pathological significance. Where there will be prominence in helix. Okay, so we have finished the important points about the pinna anatomy. We will enter into the external anatomy. This external is divided into two parts: bony part, cartilaginous part. Totally the external will be 24 millimeter length. So out of which bone will be 16 millimeter, cartilage will be 8 millimeter. We are having two natural openings in the external canal. One such is fissure of Santorini. The second one is foramen of Husky. So the fissure of Santorini is present over the cartilaginous part. This Husky is present over the bony part. Can you see over here? This is Santorini. This is Husky. Okay. So what is the significance of these two fissures and foramens? So spread of infection in and out of the ear. Spread of infection in and out of the ear is the important significance for these two natural openings. We are having an anatomical area called tympanic isthmus. See here, this is the tympanic isthmus which I am talking about. So it will be a little bit constricted area over the bony part of the external canal. 6 millimeter later to the 6 millimeter lateral to the tympanic membrane, we will be seeing a tympanic isthmus. It is the most common site for foreign body getting lodged at the extraordinary canal. Okay, so I'll tell you how. See, you look at this video. It's not a video taken from the net. See here, this is the case of ear foreign body. Can you see? This beetle is present just near the tympanic membrane. So can you see the area? The area is just near the tympanic membrane, which is at least 6 millimeter lateral to the tympanic membrane. Okay, so this is the area where the foreign body in the extraordinary canal getting lodged. Okay, so they are removing the foreign body. So this has happened to a young child of 2 years, so we can't remove entirely. They were removing in a piecemeal. Okay, it was done under general anesthesia only. Okay, fine. So understood? Fine. So that's all about the important points about the external auditory canal. Understood? Yes. Now we'll discuss about anatomy of middle ear. Okay, so this anatomy of middle ear, first we have to understand about the important word called middle ear cleft. This middle ear cleft means it involves middle ear cavity plus eustachian tube. This middle ear cavity is comprised of antrum, adytus, attic. It is called as adytus ad antrum. So these three are linked structures. I'll tell you how. You just see, this middle ear is the middle ear cavity. Okay, so this middle ear cavity comprises of, this is the middle ear cavity. Okay, this is the mastoid antrum. So this middle ear cavity and mastoid antrum is connected by a small constitutive structure called adytus ad antrum. It is called as adytus, connected by adytus ad antrum. So what are the structures which are for part of the middle ear cleft? Number 1 is antrum, number 2 is adytus, number 3 is attic, number 4 is eustachian tube. All these 4 structures are combinedly called as middle ear cleft. Whereas middle ear cavity is only middle ear cavity. Okay, so why it is? Now I will tell you a narrative. You just have to understand and remember this narrative throughout the class. So you have to compare the middle ear cavity with our living room or bedroom. You have to compare the attic portion with the air conditioner of our room. This antrum with the external unit of the air conditioner. Okay, so if you want to have a good sleep, we want to have a good ventilation and good air supply from our air conditioner. Am I right? So this middle ear cavity should be well ventilated by adytus ad antrum with the help of the external unit called mastoid antrum. If there is any problem with this air conditioner, the room become very filthy, the room become not receptive for living. Okay, so if this middle ear, adytus and antrum are in harmony with each other, you will have good ears. If there is some blockage over any of these structures, you will have an infective ear or discharging ear. That is the root cause for causing otitis media. So that we will discuss in the next class. Now that is the concept. These three should be in harmony with each other. If that's not the case, if that is blocked by some infection or some congenital anomalies, then the hearing and the infective state of the ear will vary. So with that note, we could classify the middle ear into three structures: epitympanum, mesotympanum, hypotympanum. This epitympanum is the least ventilated area more prone for cholesteatoma formation. Understood? Whereas mesotympanum will be holding the middle ear structures. Hypotympanum is not so significant. It will be having only, it forms over the floor of middle ear. It will be having few air cells, hypotympanic air cells. So these are the significance of these three subdivisions of the middle ear: epitympanum, mesotympanum, hypotympanum. Understood? Okay, fine. With that, we'll proceed to the next part of the discussion, lateral wall of the middle ear. Okay, so we started with, okay, so the middle ear is having 6 dimensions: anterior wall, posterior wall, medial wall, lateral wall, roof and floor. The most important thing is lateral wall. We'll start with the lateral wall. So this is the lateral wall. I have showed you already. Tympanic membrane forms the lateral wall of the middle ear. So if tympanic membrane forms the lateral wall of the middle ear, what are the important structure that is holding the tympanic membrane? Scutum is a bony projection from temporal bone that holds the tympanic membrane, that holds the tympanic membrane. Okay, the tympanic membrane is divided into two parts: pars tensa, pars flaccida. Okay, so this is a pars tensa. So this one is the pars flaccida. Okay, fine. Now what are the other parts? See, can you see the prominence of the malleus? This is the prominence of lateral process of malleus. That also you would appreciate. Then can you see the tip of the handle of malleus? This is that handle of malleus prominence. This is the tip of the handle of malleus prominence. This tip will form a structure called umbo. So along this tip there will be a small projection of a tympanic membrane from the surface. The tympanic membrane will not be like this. It will be a little bit projected at the umbo. This projection will result in the formation of cone of flight. This cone of flight is due to the projection of the umbo above the surface of the tympanic membrane. It is not flat like other structures. It is little bit projected from the surface. That's why it diverts the light rays when we are projecting the light through the otoscope. A cone of flight appearance. Okay. Okay, sir. So this you call it as an ideal tympanic membrane. Okay, I will show you the ideal tympanic membrane. So I'm just showing the ideal tympanic membrane for you. This is the ideal tympanic membrane. Can you see? This ideal tympanic membrane should be having, can you see? So this is right one, this is left one. It should have, this ideal tympanic membrane should have, can you see the cone of flight appearance? This is the cone of flight appearance. This is the handle of malleus. This is the umbo. Okay, so this you see a pars flaccida, you will see a pars tensa. Okay, so this is the ideal appearance of the healthy tympanic membrane. The tympanic membrane is normal. So the signs of retarded tympanic membrane. So TM will be dull and lusterless. The handle of malleus will be foreshortened. Mobility of tympanic membrane will be absent or reduced. Prominence of lateral process of malleus. The cone of light will be absent. Okay. Okay. Is that clear? Shall I proceed further, or do I need to add more points in this table? Shall I proceed? Zoom out. That's all, no? Anything else? Shall I proceed? Shall I proceed? Yes. Okay. With that note, we'll enter into the next. Yes. It's a valid question. The question was how to identify sides of tympanic membrane. Okay. So that's why I kept that here. Can you see here? You should see the projection or angulation of the umbo. Okay. This angulation of umbo okay, so this is an angulation of the umbo. Okay, so if this is towards like this, okay, towards like this, you will see a left sided tympanic membrane. Okay, so I'll draw in our workbook, make it very clear. See here, I'm drawing a tympanic membrane. So in this tympanic membrane, if this is the direction of umbo, 5 o'clock direction, it is a right side. It's nothing but this is an anterior side. That's how you should identify. Projection is towards the anterior direction, 5 o'clock direction. Now if it is a 7 o'clock direction, it is a left side tympanic membrane. So now you say, which side is this? So this is the projection point. It's a right side tympanic membrane. This one is a right side tympanic. Understood? This is how you should differentiate between a right sided tympanic membrane, left sided tympanic membrane. You just imagine yourself, the umbo is tilted towards which side? If it is tilted towards which side? Okay, fine. Anterior wall of the middle ear. The anterior wall of the middle ear is full of canals. 1, 2, 3. The first canal is canal for tensor tympani muscle. The second canal is Eustachian tube. Third canal is canal of Hoogier. Exit point for cauda tympani. Okay. Now, so anterior wall we are having upper, like we are dividing into three portions: upper one third, middle one third, lower one third. This upper one third will be having this canal for tensor tympani. The middle one third to lower one third will be having Eustachian tube canal. This canal of Hoogier will be having exit point for cauda tympani. Okay. Then medial wall of the middle ear. This is very important. You just have to make a look into it. This is medial wall of middle ear. Can you look into the middle of middle ear? Now, in this middle of middle ear, we are having oval window, we are having round window, we are having prominence of the inner ear, and also we are having a facial nerve which is crossing the area. Okay. Can you see here? This is the middle wall of middle ear. This is the oval window, this is the round window, this is the promontory which we are talking about. Now, can you see over here the superior most part of the, yeah, I'll repeat it. Okay. So this is the oval window, this is the round window, this is promontory, this is the superior most part of the middle wall of middle ear. So in this superior most part of the middle of middle ear, I'm going to cut a bony portion from it. When I cut a bony portion from the superior part of like this, can you see? Can you see the yellowish structure visible on removing the bony portion? That yellowish structure is called facial nerve. So the bony portion which is surrounding the yellowish structure is called as fallopian canal or facial canal. I am talking about middle wall of middle ear, which is the most important walls compared with other dimensions. It is having oval window, round window, promontory, and is having a canal called facial canal. And then it will be having a area called, see here, can you see here? This tensor tympani tendon is having one communication here. Okay, this tensor tympani tendon is having one communication here. Can you see? That communication name is processus cochleariformis. Okay, so now I hope you understood the orientation of these structures. With this orientation, we shall write it down in a workbook. First one, the prominence. What is the prominence? Can you see? So this is the prominence which I'm talking about. The prominence is nothing but, if this is the middle ear, if this is the inner ear, this inner ear will form prominence like this. So this area will look projected. The projection or prominence is due to the inner ear which is pushing the middle wall. The prominence is due to the cochlea of inner ear. Understood? Fine. Posterior superior to promontory, you will be having a oval window. Posterior inferior to promontory will be having a round window. Okay. Posterior superior to all the structures over here, we are having a facial canal. Anterior superior to all structures, we are having a processus cochleariformis. Processus cochleariformis. Now the important relation is this oval window is inferior to this facial canal. This process cochleariformis is anterior inferior to this. Anterior inferior structure is process cochleariformis. Okay, that's the thing you have to understand. Along the promontory, you will be having a group of nerves called tympanic plexus that we will discuss while discussing about ear pain approach. So now these are the structures. The first one is prominence of cochlea of inner ear, then two windows. Oval window, round window. Understood? two bony covering. Okay, so now one bony covering is facial nerve covering. We call it as facial canal or fallopian canal. Very, very important. Facial or fallopian canal. Another structure is, you just look into this three-dimensional picture. Can someone say, see here, if this is the medial wall of the middle ear which I am talking about, now this is the facial canal which I am talking about. Can you see the facial nerve? Yes. Just superior to the facial nerve, what you are seeing? Can you see another bone which is exposing just above the facial nerve? Now I am going to cut open that bone also. Can you see a bluish structure? So it is lateral semicircular canal, which is even posterior superior to facial canal. This is a beautiful depiction. Can you see here? So this is a facial nerve which is covered by a bone. I have cut a piece of bone from that. Just above the facial nerve, we are having a dome of lateral semicircular canal. I am cutting a piece of bone from that. You are seeing the membranous labyrinth over that. Okay, so this is a very, very important point. All structures are inferior to facial nerve or facial canal in medial wall of middle ear. One structure which is inferior, where the facial nerve is inferior, is dome of lateral semicircular canal. This is the area, dome of lateral semicircular canal. So what are the next bony covering? Dome of lateral semicircular canal. What are the two bony projections that you will see? See here, I am having two bony projections. So one bony projection over here, one bony projection over here. Okay, so this picture will be little bit clear in the corresponding slides. You just write it down. The bony projections names are ponticus and subiculum. Ponticus and then subiculum. So processes cochleariform is nothing but attachment for tensor tympani tendon. Contents of the middle ear, we are having malleus, incus and then stapes. The malleus is hammer shaped bone, incus is anvil shaped bone, stapes is stirrup shaped bone. The malleus attaches to tympanic membrane. That is the first point. So the malleus tensor tympani attachment is there. The stapes, first we'll write down stapes, then the incus. Stapes attaches to oval window that leads into the inner ear. It has stapedial tendon attachment. Now, the one which is between these two ossicles is incus. The incus has no muscle and is in between the ossicles. So it has least blood supply. During disease like cholesteatoma, this is the first ossicle to erode. If they ask you which is the first ossicle to go for erosion during cholesteatoma or any infective pathology of the ear, the first ossicle is incus because it is having feeble blood supply, because it is having no muscle attachment, and also it is not attached with any adjacent structure. So that's the reason it is having least blood supply, so it is more prone for erosion. Muscles, the tensor tympani muscle attaches to malleus. It is supplied by mandibular nerve. Stapedius supplied by facial nerve. So all the first arch are supplied by mandibular nerve. Second arch are supplied by facial nerve. You should be very clear with that. Now I'll tell you one point. Stapedius is, both of them will dislodge the ossicles, and prevent hyperacusis. What do you mean by that? I'll tell you one concept. The Diwali is around the corner. So you are waking up by 6:30 in the morning. You are having an oil bath. Okay. You are wearing your new dress. But the first atom bomb that you hear on that day, okay, whatever religion you are, okay, so you will be facing the Diwali Rath, no? The first atom bomb that you hear on that particular Diwali day, that will bring headache for you. That will bring headache for you because you are not prepared for that loud sound. Your neighborhood kid will be burning a sound atom bomb that will give you a headache. Whereas for the subsequent time of that particular day, you will hear at least hundreds of atom bomb sound. Do you get headache for all those sounds? No. Am I right? Because this ears will get accommodated in such a way that you should not hear loud sounds. So that is called reduction of hyperacusis by these two tendons of the ossicle. It is called as stapedial reflex and non-stapedial reflex for reducing hyperacusis. It will dislodge the ossicles. Only if the ossicles are intact with each other, it will conduct the sounds. If the ossicles are not intact with each other, it will not conduct the sounds. As it is not conducting the sounds properly, there will be gross reduction of the sound. So that will prevent hyperacusis. Okay. So if it is done by stapedial tendon, you call it by the name stapedial reflex. Okay. Through the facial nerve. Done by mandibular nerve, it is called as non-stapedial reflex done by mandibular nerve. So it's very, very important. They may ask this as an MCQ. Clear? So we have finished the middle wall and the contents of the middle ear.